Presenting for us today, we have Dr. Avi Nath. He's with the National Institutes of Health, where he serves as Chief of the Section of Infections of the Nervous System at the National Institute of Neurological Disorders and Stroke. So welcome. Thank you for joining us today, Dr. Nath. And I am going to go ahead and get your slides up.
Yeah, thanks very much for the kind introduction and for an opportunity to address you here on long COVID, which has become a real passion for me and our group because it dovetails on our studies. As I was discussing with Dr. Chow earlier, we've had long-standing interest in HIV infection, and you have the same issues, viral persistence despite adequate treatment. And so what we've learned from HIV, we've applied to COVID, and I'll show you how that synergy in knowledge really occurs and what kinds of um, pathophysiological mechanisms may be responsible here. So, as you mentioned, at the National Institutes of Health, this is right outside of Washington, D.C., and they in the town of Bethesda, and they're in about 440 acres of land. This is the intramural program. And this building in front of you are three different buildings put together, and they're called the Clinical Center, or Building 10. And this is the building where it serves as a hospital. So we have patients that come in here. We have an outpatient center, an inpatient center. And what we don't have is an emergency room. So most of the patients we see usually have chronic illnesses. They get acutely ill. We do have an ICU, but we don't bring in like acute stroke or heart attacks or something like that. Okay, so a lot of the long COVID patients that I'm going to talk to you about are all that we've seen over here. Yeah, next slide. No disclosures. That's one thing about working for the federal government is you never have any disclosures. Sometimes I wish I had some. Okay, so this is a article that was published not too long ago, but it's a interesting concept. And so what it shows is that you have the virus, it's infecting some cells, is replicating there. That's on the left upper corner. And it can have several outcomes. So you see the red arrow, it says it can actually kill the cell, it can have a cytopathic effect, right? You can have an immune response against it. So now you get an immune effect, right? Now, what's going to happen is that you have several defense mechanisms against the virus. So the immune system is going there to attack the virus, and in doing so, it can cause bystander damage, right? So they can cause symptoms just from the inflammation. The cell itself, when it's infected with the virus, is going to do something to it. It's going, well, I'm going to try to suppress it. It cannot kill the virus. It doesn't have all the tools, but what it does is it tries to suppress it from doing its job because otherwise they get killed. So it can result in this persistent infection if it's successful in doing it. It stays there in small levels, right? Sometimes it can make it totally latent, right? And if it's totally latent, then from the latency, it can get activated from time to time, and it can release viral particles or viral proteins, what have you. The immune system, if it's persistently replicating, is going to recognize it and it's going to still try to get rid of it. But if it's unable to do that, then the immune system will get exhausted. And what gets exhausted are usually the T cells. When the T cells get exhausted, you have the macrophages that then start producing all kinds of cytokines and oxidative stress, but they're not very effective in getting rid of the virus, but they cause a lot of bystander damage. So that can cause a lot of different symptoms. So this mechanism here is operative in most individuals to a different degree. Right? Some can be very efficient at getting rid of it, some are not. And if you're not, then you got all these other problems. Okay, next slide. So, so I'm going to talk to you a little bit about how the virus really enters the human body and where it resides and what is the evidence that it persists. Right? So what we all know is that it is a respiratory tract infection. We know that at least in acute COVID, you remember the early parts of the pandemic, there was all this stuff about, people, you just breathe on someone and you'll be producing trillions of copies coming out of their nose. I mean, just copious amounts of virus. The thing is, where is all this virus in the nose, right? And what it does is it goes into the nasal mucosa, and there it infects these cells called the sustencular cells. These sustencular cells are support cells surrounding the neurons there. You have the olfactory neurons, and around them are these sustencular cells. It infects these cells. And as you can see on the bottom left is an electron microscopy, and all these small black dots are viral particles. So you can see there's a huge amount of virus just sitting there in the nasal mucosa. Mm. So we thought that at that time, if you have all this virus there, that right on the upper border of your nose is this very small, thin piece of bone called the cribriform plate, right? And so we thought that the virus will just go along those holes in the cribriform plate and get into the brain. In fact, there may be a little bit of evidence for it, but it didn't really pan out. And I think for the reason is that it doesn't infect the neurons themselves. If it infected the olfactory neurons, then it would get inside the cell. It would go in very easily. But when it infects the sustencular cells, it doesn't really get a chance. So you can see at the bottom right, the Germans did this very interesting study. At autopsy, they collected in the olfactory mucosa, the olfactory bulb, which is already now inside the brain, and the olfactory tubercle, which is further down. And they said, okay, how much virus is there? You can see at the bottom is where you find absolutely no virus. And as you go up a little bit, you can actually find virus. So in the olfactory mucosa, there's a lot of virus. If you go to the olfactory bulb, you have only 3 people who had a little bit of virus. And the olfactory tubercle, only 1 person. So the virus doesn't really cross into the brain that easily. Right? It stays in the nose, doesn't go into the brain very easily, except for a few exceptions. Okay, next. This is a study done by a group here at NIH, and what they did was they got these autopsy samples, and they did digital PCR, and they had a very highly sensitive digital PCR, and they show you how much RNA they found. Okay, so the right-hand column is the RNA, and they tell you how many days post-infection, because these are autopsy studies, so you only go at one time point per person. And what you find is that in the respiratory tract, even if it's less than 14 days, you got a lot of virus there, right? 9,210 copies of it, right? That's their average. But as soon as you go greater than 31 days, it's less than a copy. So the viral load disappears very rapidly, even in the respiratory tract. Now, if you go into the brain, look at the bottom over there. Less than 14 days, you have 32 copies. Greater than 31 days, less than a copy. So the virus is not that good at getting into the central nervous system, right? And when you just make a mush of the brain, you say, okay, it's in the brain, but you don't know where in the brain it is. It could be sitting inside the blood vessel, outside the blood vessel, that in the extracellular space, is it actually infecting anything? If it was infecting things, then you should find it there even a month later, right? Okay, next slide, please. So what we did was we had an opportunity, it was a rare opportunity. We had a patient, there's a single patient who was admitted to our hospital and was going to undergo, a resection of part of the brain for epilepsy surgery. So the patients who have intractable epilepsy, what they do is sometimes they'll go in there, they'll map where the seizure is coming from and go and cut it out. And when you cut it out, you can actually cure some of these patients. So this patient came in, and in order to do that, they opened the skull and they put electrodes there. They want to make sure that whatever they're going to cut is really the right part. That's where the epilepsy is coming from. It's not that simple. You got to record from the brain for several days. So while they were doing that recording, this patient actually developed COVID. Right. Patient developed COVID. They had to stop. They said, "Well, we can't do the surgery right now. We'll wait for a few days till the patient gets better, and then we'll do the surgery." So they waited a few days. Patient became PCR negative. At that time, we didn't have the antiviral drugs, and they went in and did the surgery. the surgery, we took a little piece of that brain. We said, okay, can we find any virus in here? Patient had no CNS symptoms of the infection was very, very mild. Patient recovered just fine. When we looked at the brain, we pulled out the exosomes and we looked in there, we found that we could find the nucleocapsid just fine. Okay. So we didn't find the other antigens, spike protein or whatever, but we found the nucleocapsid. And you can see that little band over there. Mm. So to us, that was actually very fascinating that you're finding a restricted viral replication, which means you're finding some proteins but not all the others, and you're finding it very early on in the course of infection. Now, we followed this patient for a long time. She never developed any CNS symptoms whatsoever. So it could be just transient and it disappeared. Who knows? But it is interesting that at least it can be detected and it could be restricted even early on. Okay, next question. Next slide. Now, this is a group from the National Institutes of Aging, here again in Bethesda. And what they did was, people lose taste. So they said, okay, let's look at the tongue papillae. Now, I didn't even know you could do this stuff, but what they do is they take little biopsies from your tongue. But it's just the little papillae that are just sticking up on the tongue. So they go and just snip it. Apparently, it doesn't hurt that much. And then they looked at it under the microscope. But the interesting thing is that these individuals were long time after they had recovered from COVID. So here you're seeing a photomicrograph on the right bottom of a person, 45-year-old woman who's had 40 weeks post-infection, right? So that's a long time. So, and then when they immunostained it for various antigens, you see the spike protein is green and the capsid protein is red. And you can see that it overlaps with yellow. So there's a lot of viral antigen sitting in the tongue papillae. Very interesting, right? So it's not producing fully replicating virus, not like the virus is coming out of your tongue, but the antigen is still sticking over there that long. Okay, next question. Next slide. Now, this is a group from San Francisco. And what they did was they did rectal biopsies on patients with COVID. And here also on the left-hand side, they tell you how many days after. But some of them are almost a year and longer, right? And on the right-hand side, all this brown color is where you find the spike protein that they immunostain for. And this little inset there at the bottom is where they did some RNA scope. So they found the RNA. And so that reddish color there is the RNA. So they found both the protein and the RNA in the rectal mucosa. So you can see that now you have a viral antigen that can be detected on multiple anatomical sites, but they're not producing virus out of the rectum. Right? It's not fully replicating virus, but the antigen is sitting there. Yeah, next slide. Okay, now this is a group from Boston, and what they did was they looked at serum of patients. Now they developed a highly sensitive assay, which is the Samoa assay. So you can go down to very, very low copy numbers. But that's what it takes. You just did an ELISA or something, you're not going to find it. But you have to go through these very high. And they had multiple samples per patient. And you can see that they looked at the S1, the spike, and the nucleocapsid protein, the N protein. And what they found was the spike protein to be most commonly present in the serum compared to the other proteins. So they're finding something, and some of them are 10 months post-diagnosis. Right? So this protein is coming from somewhere. Okay, next slide. Now, this is an interesting paper. What they did was they looked at the detection of, again, the S1, the spike, and the N protein. But now they say that, well, there are the multiple cohorts. Is this something unique to the Boston group? Maybe their patients were somehow not very well controlled or something. Or can you find it in other groups? So there are 4 different cohorts of individuals, and they looked at each one of them. And they divided them by how many months post-infection. So you can see they have 8 to 14 as the last column there. Well, you can see that, yes, early on, you can find a lot of spike protein, for example. And then as time goes down, it goes down, but doesn't disappear. You can still find it in the serum of these individuals a year later. Mm. And you can find it in almost all these cohorts, right? So I think that's also quite interesting. Okay, yeah, next. Yeah, this is again. This they looked at RNA for the COVID antigens, and they found in a number of different organ systems at autopsy, you can find RNA. Mm. Variable levels, that is, but still there. Okay, next slide. Okay, now we did a little bit different here. What we did was we said, okay, let's look at the immune system and see, are there any abnormalities in them. If you just run the garden variety, immune panel, it always comes back normal in these individuals. But here we did something different. So we did flow cytometry and as a research tool. And what we found was that the B cell frequency, so PASC is nothing else but long COVID. Okay. So, and HV are healthy volunteers. So what we found was that there was an elevation in B cell frequency in the long COVID patients. And interestingly, is the antibody secreting B cells that were much more elevated than the others. The question is, what type of antibody are they secreting? So on the right hand side, on the upper three little graphs there, they are from a paper published by the group at Johns Hopkins University, and they are rheumatologists. And what they did was they looked at what they found. They said that is very interesting is that over a period of time, these individuals have IgG and IgM. And what happens when you get an acute infection, you should make that class type switch. For some period of time, you produce IgM, and then you should produce IgG. Instead, what happens is that these individuals with COVID, that have long COVID, they don't make that switch. They're stuck in the IgM level, and they don't go move to IgG. IgM is not a very good antibody, at controlling anything. IgG is what you really want. If you're not able to produce IgG, it's not going to be a good immune response. Right? So the B cells are defective. There's a block in the B cells. Okay, so then what we did was we did flow cytometry on the T cells and on all these cells, where we looked at the T cells. And what we found was that there was an elevation of TIGIT, which is a checkpoint inhibitor. So these are things that get activated on lymphocytes once they are getting exhausted, right? So one of these checkpoint molecules is called TIGIT. So it was increased in patients with CD8 infection. In fact, you can see that, and we did it over first and second visit, which is a year apart. So in fact, the number of cells with TIGIT went up over a year. It's not going down, actually it's going up, right? They're getting exhausted. We looked at PD-1 ligand here on monocytes, and you can find on some individuals it went up over a year, the others it went down. But even if it went down in some of these, it was still elevated, right? Still elevated. Now, this is another published study here, and what they did was this Yin et al. They said, why don't we look at another checkpoint molecule, which is called CTLA4, and we look at only those T cells that we know are directed against SARS-CoV-2. Because they're looking at a very small subpopulation against it. And they're looking for the presence of CTLA4 and PD-1. So they should be double positive for two checkpoints and should be T cells that are directed against SARS-CoV-2. When they do that, you find that there is a higher proportion of those cells present in patients with long COVID. That is a very clear indication of T cell exhaustion in these individuals. Okay, next slide. Now, this is a group from the Netherlands. And what they did was Um, they did a PET scan study, and they used a ligand that will bind to activated microglial cells in the brain. Mhm. And if it binds to the brain, there's a radioligand. They produce these pseudo colors. You get these yellow and red. These are these very bright colors on your scale. That means it's a lot of uptake. If you're down in the blue, you know, the bottom of the scale, that means the brain is cold. Nothing much is binding there. So in these long COVID patients, you can see the humongous amount of activation of microglia in the brain. Now, this is one of the first studies that were published, but since then there's several studies that have confirmed this observation. Okay. What we did was we looked at autopsy specimens, and you know you have these four boxes. The left two are control, and the right two are COVID patients. All these brown staining cells are microglial cells that are activated. So confirming pathologically that you have activation of microglia in these individuals. Right? And we quantified that, and you can see that on the right-hand side of the graphs. So that tells you that there's definitely microglial cell activation taking place. Microglial cell activation is bad news. Usually, what happens is once you see that, it's going to produce all these cytokines and oxidative stress and start killing neurons and other bystander stuff. So you want to be able to control these things. Okay. Okay. Next slide. So the question is, why do you have that kind of microglial cell activation? So what we did was early in the pandemic, when these patients were dying, we didn't know where to cut, and getting autopsy tissue was no easy task. We got them from the medical examiner's office, but through the Department of Defense because they didn't know what was wrong with these patients. They had done autopsies, and in fact, when I was looking for tissue, I contacted them, and they said that, you know what, we don't have any COVID patients. For COVID patients are positive, we just put them in a refrigerated truck, and they had 200 bodies sitting in a refrigerated truck that were going to be cremated. What they didn't know is they'd already done autopsies at the medical examiner's office because COVID came through New York, and they didn't know that they have had COVID in their population. But when they looked at the pathology, they had no idea what was going on. They sent it to the Department of Defense because they have a contract with them. And the neuropathologist there, Daniel Pearl, called me. He said, "Listen, Avi, this is a, uh, COVID brains here. Do you want to study them?" I said, "Sure." But I said, "How do I study them? I don't know where to look. I got the whole brain here." And so we had these very high resolution MRI scanners, 7 and 14 Tesla scanners. And normally nobody would let me touch them. But during COVID time, everybody was sitting at home, and everybody was trying to figure out, is there some way they can actually get out of their house and do something for COVID? So I had full access to the MRI scanner, and we scanned the brains, and we found that there were these arrows are these small blood vessels that look totally abnormal. And so, but you can see the anatomy is just gorgeous. So this is the pons that you're looking at. You can see all the fiber tracks and everything. Never seen on a regular MRI scan ever. So we looked at it, and then we made sections from the exact same area that we saw in the MRI scan. And then we immunostained it for various kinds of things. And this one is immunostained for fibrinogen. Fibrinogen is a very large protein. It stays in the blood, it never leaks into the brain. However, what we found, all this brown staining, is fibrinogen. It's leaking into the brain. And not only that, you see very dense staining around the blood vessels. And the further away you go from the blood vessel, the less staining you see. So that's telling you that the blood vessels are defective, and this fibrinogen is leaking into the brain. So you have leaky blood vessels. We even looked at the olfactory bulb. I mean, nobody's ever done an MRI scan of an olfactory bulb before, but we did that. And what we found was there was a humongous amount of fibrinogen sitting at the olfactory bulb, just huge amounts. Okay, next slide. So we started asking the question. We said, what is the pathology around these blood vessels? We said, okay, let's look for macrophages. We found that they were sitting all around the blood vessels. Kind of makes sense because if you have all this fibrinogen and leakage from the blood vessels, something's got to come and chew it up. And so the macrophages are the right thing to do so. The problem with the macrophages is that they're uninvited guests. So once they get in, they don't leave. And then they cause a lot of destruction. So then we also found that there's a lot of astrocytes that are activated there too. Then we started looking for T cells. That's very important because if there is virus in the brain, T cells will go and attack them. Okay. So if you find cytotoxic T cells or CD8 T cells in the brain, you know there's virus there. We just need to find it. But when we looked at it, and that's been the experience of a lot of other neuropathologists, is that we found the T cells in the blood vessels, around the blood vessels, never in the parenchyma, never in the parenchyma. So that tells you that there isn't much virus in the brain, but it may be at in and around the blood vessels themselves. All the pathology is at the blood vessels. We found other blood vessels there, all these brown staining you see on the right hand side. That's all these platelets just sticking over there. You find these little clots forming of platelets. So that means these platelets are activated and they're sticking to the endothelial cells. Right? Yeah, next slide. Now, if you have vascular pathology, so this is a very interesting photomicrograph that I just borrowed from the web, and what it shows is that there's a huge amount of blood vessels in the brain, and that there's no cell that is more than a few millimeters from a blood vessel. So if you affect the blood vessels, you're going to affect a lot of the brain structures, right? And sure enough, in some of our long COVID patients, as you can see here in these MRI scans, these small white dots that you see, that is indicative of microvascular disease. And so we see this quite often in the long COVID patients. The next slide. Okay. The other interesting thing is that we looked at the brain and the medulla of the brainstem. You can again see with this 11 Tesla scanner here, the anatomy of the medulla is just incredible. You can see all the nuclei there. Some of these patients that came to us had died in their sleep. So we thought there must be central apnea, which is called Ondine's curse. And I thought that was very fascinating because that means if there's infection in the lungs, maybe it can travel up the vagus nerve because the vagus nerve innervates it. The vagus nerve is coming from the medulla of the brain. And if the virus is going up there, it'll get into the brainstem. And maybe that's how it's getting into some parts of the brain. And the pre-Bodzinger complex, which controls the respiration, is right next to the vagal nerve nucleus. So I said, let me go and look at these nuclei and see what I find. And what we did then, we found these macrophages, the CD68 macrophages, just around these neurons over there. And the neurons look extremely atrophic. The bottom right one, you can see that you have these microglia, which are these blue staining nuclei there, and the neurons look shrunken. So this phenomenon is called neuronophagia. You get activated macrophages, they'll chew up the neurons. Right? So we think that some of these patients were probably dying from central apnea. Yeah, next question. Next slide. So what are we doing for these patients? So we're doing a couple things. One is so there are a number of trials that have already been done. Right? People have done a lot of trials for symptomatic treatment, huge number of them. Disease-modifying therapies have been very few, not as many. So, but here are a few. The sad thing is that all these placebo-controlled studies have all failed, one after another. So pharmaceutical companies don't want to invest in long COVID. And why are they failing? Either we have the pathology wrong, or it's a very heterogeneous disease, and you're not really studying one disease, you're studying multiple diseases under the same umbrella. Right? So that is a real challenge. But the first thing was that people wanted to say that, okay, maybe there's persistent virus. You're never getting rid of the virus. If we just give you the Paxlovid instead of for 5 days, which was the usual course, why give it for 10 days? Why don't we give it for 15 days? Let's keep giving it, see, maybe it'll make a difference. And they've done now 3 or 4 placebo-controlled studies. Keep giving more and more Paxlovid and don't do a darn thing. They didn't do anything at all to the long COVID. No, so that's not the answer. Then there was a group from Houston. They did stem cell therapy. And so, listen, we give stem cells. It's going to be protective. It's going to have all these growth factors. It'll be good for these patients. And the woman actually called me before she was designing the study, and she was very motivated. She spent her own money, whatever she had, put the study together. And then she called me, and she was very upset because she says she broke the code and she found it didn't do anything at all, right? And she never published it either. So there was a very strong placebo response, no effect of stem cells. Then there's a group called a company called Genuro, which is out of Switzerland. They found that macrophage activation, they have an endogenous retrovirus called HERV-W. They showed that when macrophages get activated, you see a lot of HERV-W. They had a monoclonal antibody to block this that they were going to use in multiple sclerosis patients. Long COVID came along, they said, you know what? Why don't we just do it in long COVID? Now, they didn't have the money for it. They went to the European bank, borrowed 8 million euros to do the study. They unblinded themselves. They found it had no effect. No effect on the primary endpoint, no effect on the secondary endpoint. And the company had to declare bankruptcy. The study never got published. Right? The problem was that, and I had talked to these guys too. And I said that, listen, instead of enrolling everybody, what you need to do is identify the individuals who have elevation in HERV-W and then do it. When they did a analysis after the fact, there was a small subset, about a third of these patients who had elevation in HERV-W, and they did improve with the antibody, but it got washed out in the whole thing. And by this time, these guys are bankrupt. Yeah, that study's over. Game's over. And then there's another one on lithium. Okay, well, lithium will do a lot of good for you because it has all these cognitive effects. It treats all kinds of psychiatric things. It also boosts your immune system. So good rationale, didn't do anything at all. Okay, so next slide, please. All right. So what has worked, right? Now, if you treat acute COVID with antivirals, with Paxlovid or whatever, you treat it very fast. You can prevent the development of long COVID or the severity of long COVID. Now, that is an interesting fact. That's when you do have virus. And it makes sense that if you can control the virus, you don't want a lot of virus in your body. If you get it, maybe keep it under wraps. Your chances of developing long COVID will become less. Okay? So there are several studies that have shown that. So I've listed two of them, but there are more than that. Yeah, next one. What is the other thing is vaccination, which is another interesting aspect. The vaccination is not without side effects, at least on the early parts of it. But what they did show is that if you take the dosage of vaccination matters as to how many times you take the vaccine. If you take only one dose, doesn't make a difference. The way these hazard ratios work is that the dots, the more they are towards the left, means there's a less chance that you develop long COVID. Okay. So you can see that as you go and you're taking, so you have one dose and you have two dosages and you have three dosages, and you can see that the more dosages you get, the better the chance that you're not going to develop long COVID. Right? And then there's this European guide here. They did a whole bunch of other meta-analyses, and they also found the same thing. And here there were all multiple dosages, and they found that the more dosages you get, the better off you are in preventing long COVID. So I've taken eight dosages already. Yeah. All right. Okay. Next slide, please. Okay. So I said that there could be antigen persistence, but I don't know how often it is, where it is, and I showed you there's some evidence for it. So I said we need to look at it. So we're now enrolling patients who want to come here to NIH, and if somebody wants to come, you're welcome to. We'll pay your transportation and everything and reimburse you for the rest of the study. And what we will do is, but we'll take every single body fluid, and anything we can biopsy, we will biopsy it. And so that we really want to find out if there is persistent antigen or not, right? That is so critical, because if it is, then the treatment has got to be very different. Yeah, next question. And next slide. So, okay, so I'll tell you a little bit about that study. Yeah, next one. So it is registered on clinicaltrial.gov. You can actually see it there if you want to. Yeah, next slide. So the primary objective, of course, is to uh, identify the viral reservoir in patients who have complaints of long COVID. And since I'm a neurologist, we try to enroll patients who have neurological symptoms. Right? And the secondary objective is that we also want to see patients who are fully recovered and see if we can still find evidence of viral antigen in them. If we only look at the long COVID and find antigen, we'll can make the wrong conclusion that it's the antigen that's driving the symptoms. Uh, if patients who are fully recovered, if they also have the antigen, then maybe the antigen is just a bystander. But if the ones that have recovered, we don't find any or find very little, and the ones that have long COVID, we find a lot or exclusively in them, then I think it'll support the hypothesis that we need to do something about it. Okay, next slide. Okay, so these are our entry criteria. So we have these patients with long COVID, and it should be all adults, and symptom burden should be moderate, and could involve any of the uh, systems in the body. Mhm. And then we have those that recovered from COVID because we like to be able to see them as well. They should have mild symptoms if they have any persistence. Okay, next slide. So what we do with them, the first we do a screening visit, try to make sure that they have what they said they have, and it's not explained by some other disease. Sometimes people have, all these multiple system symptoms, and they can attribute it to long COVID. But when you study them in detail, you find out actually there was an unrecognized systemic disease that didn't get treated. Next slide. So then, as I said, we'll take a lot of body fluids and biopsies of various parts, in a safe manner. Next slide. This is our study team for this study. Yeah. And I'm the PI. Yeah, next slide. We have some other ongoing studies. One is for IVIG. So this is a double-blind placebo-controlled study. You'll get IVIG, one course of it. And even if you get placebo, it's a crossover study. So you don't know what you get the first time. And the second time, you get the other thing. So eventually, everybody gets IVIG. Mm. And the PET study, we have changed now. So we're not doing this exact PET study, but we're incorporating into another study. I'll show you on the next slide. So this is looking at another therapeutic, which is called pembrolizumab. This is to reverse the exhausted T cells. Okay. And here we will do PET studies before and after, but it's a safety study. We can only enroll 10 patients. And this is just starting to enroll now. So if anybody's interested, now is a good time to approach us. And the idea is to stimulate the immune system to get rid of the persistent antigen if there is any. Yeah. Next. So, all these things are not possible without a large team of individuals. And so I have a clinical team that have done a lot of work on these patients. And then I have people in the lab that are doing various kinds of things to try and understand the pathophysiology. The next slide. There's one more. Oh, yeah. Oh, no. The previous one, sorry. Yeah. And so, we've got multiple institutes that are involved in these studies. And so everybody has a part to play in collection of samples, analysis of samples, and they have expertise in various areas. So the one good thing about the intramural program is you can really collaborate across institutes very easily. So I'm grateful to each one of them for participating in these studies. So I'll stop here, and take questions. So we still have time, right?
Okay, yes. See, it looks like we do have some questions. So Dr. Chow, do
I
you want to go ahead and start
yeah,
it off?
sure. Yeah, so I was going to ask other individuals if they had questions. It was a pleasure speaking to Dr. Nath right beforehand. He and I had through our HIV STIRP program had met one another long ago when he educated us on neurovirology, and so it's a pleasure having you. So Yvonne had mentioned, does anything in your long COVID research translates into ME/CSF?
Yes. So there's overlap between ME/CFS and long COVID. Some patients have a lot of the symptoms of ME/CFS, but they're not all exactly the same. So long COVID, compared to these long-term ME/CFS patients, are less affected. We don't see the post-exertional malaise that often in long COVID. While that is an essential feature of ME/CFS. So I think that's probably the major difference between the two.
I had mentioned, can you kind of describe the differences between viral persistence and viral antigen clearance? Do you think that it's maybe the virus isn't there anymore? It's just due to viral clearance, an issue of
Yeah.
viral clearance?
Yeah, so you're right. So you have viral persistence mean that the entire virus is there intact, but it's present at very low level of replication. So it's not killing the cell that it's actually present in, and but from time to time raises its ugly head, and it'll produce its progeny and let them go, and and so that's what we call viral persistence. So if you have viral persistence, antivirals will still make sense. But while antigen clearance is that you now have only bits and pieces of the virus. So you may have some RNA, could still have an open reading frame, it could probably transcribe a protein, but it'll never form the complete virus. Or you can have the protein sitting around that's not getting degraded for whatever reason, just stuck there. And so that is very different because there your antivirals are not going to make a difference because it's not really replicating. Um, it's only sitting and producing the protein. Mm.
And is there any way to clear viral antigen?
Yeah, and so you have to clear it. It can clear spontaneously sometimes, which is that is also quite fascinating. But we always thought you had an infection and you would, recover in 2 weeks or something like that. But more and more we're seeing with COVID, and I'm sure some of you have had that same experience yourself. That it takes a while before you get better. Sometimes it can take a few months, and there's some individuals who can take a year or 2 years, but then when they get better, it's like boom, they've recovered. And until then, they're going from doctor to doctor, and people are telling them, "Oh, there must be something in your head," and like calling them psychological. They start thinking maybe I am having psychological problems. Then all of a sudden, out of the blue, boom, it's gone. So that's why I believe in this viral clearance theory a lot. Yeah, I think that there is something about this antigenic persistence. And if you're able to clear it at some point in time, you can make a real difference with these people. Mm.
Yeah, we've seen a couple of patients who, after a year or so, suddenly do clear, and those are the most joyous patients to be with.
Yeah.
It's remarkable that they make a recovery.
Yeah.
Unfortunately, majority of the patients that we see,
So,
unfortunately, don't get better or are stuck in their current
yeah.
clinical situation.
Yeah.
Do you think monoclonal antibody therapy would somehow help with that, or?
Yeah, I'm doubtful because the thing is, it's not spreading from cell to cell, right?
Mm,
And so the monoclonal antibody is directed against a particular epitope, and it'll neutralize the entry of the virus. But we're not seeing replicating virus, we're only seeing the antigen. So the antibody may not interact with the antigen in that manner.
mm.
It could still do its own thing. And it's also possible there's RNA sitting there, and the antibody is not going to do anything to the RNA. The RNA can still stimulate TLR receptors and, a whole host of things. So, yeah, so I know people are trying the antibody, but I'm not sure that's going to do a whole lot.
Got it. Yeah. And then you pointed towards a negative checkpoint inhibitor, but are there risks involved with negative
Yeah.
checkpoint inhibitors, and
Yeah.
how do you safeguard against the adverse
Yeah,
effects
absolutely
of
right. And I think everybody worries about that. These things can cause an autoimmune syndrome sometimes. Certainly, we see them in the cancer patients. But the few things to think about. Number one is that in the cancer patients, we're giving them for several months to years, again, repeated dosages. Here, and if you have persistent antigen, you don't need to give it for that long. My guess is 2, 3 dosages may be sufficient. And you don't really, even in cancer patients, when you give few dosages, very rarely will you find autoimmune side effects at that time. And what you can do is you can screen your patients before you give them. So we do make sure they don't have any subclinical autoimmune disease of some sort, at least to the best that you can. Yeah. And if it does occur, I mean, it's still not the end of the world. You're under the physician's eye. You give them corticosteroids. You can, remove the antibody if you had to plasma freeze them or whatever. So you can, multiple things you can do. Mm.
My
But if you
last one
can make
was
a difference with the COVID, it may be worth the little risk.
yeah.
Yeah.
I had just had my last one was just a specific brains that you had brain sections of various midbrain, and also is there a specific region of the brain that the COVID would have viral persistence or
Oh,
effects?
yeah.
I,
We
I
don't know that answer.
mm, okay.
Yeah.
Yeah, I saw that you had David uh, some of the autonomic specialists on your
Yes. Yes. Yes.
collaborators. So,
Yeah. 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 So autonomic dysfunction is a major part of long COVID, and that's a good objective measure that one can use. If you're doing any kind of clinical trial, you can see if something is really changing there or not.
mm.
But yeah, that's a major feature in these patients.
So, but there's not a specific brain region that you are specifically studying.
Yeah.
Okay.
So not us. Now the Germans did an interesting study. They published one in Nature Medicine. What they claimed was that they could find some virus in the brainstem. They could find some in the olfactory bulb, and they were saying that okay, well, it is possible that maybe some virus does go along those pathways, and there's only one synapse between the olfactory bulb and the brainstem. I never realized till I saw their study. And so they claim that maybe in some of these regions you might find more viral antigen or viral persistence. But otherwise, it's so hard to find it in the brain.
Mm.
It makes it very hard to know where the predilection might be. Yeah.
All
And then
right. And
Catherine was,
looks like we
could we
do
just,
have another question.
yeah.
And it says dengue and corona have this antibody dependent enhancement. Is this the reason some people get so sick from the vaccination?
Yes, I think the post-vaccine symptoms are of great interest right now. So, the current administration is very interested in trying to understand that. In fact, we just had a meeting yesterday about that as to how to go about looking at studying this. So, I don't think anybody has the answers for it. I think you're right. People were worried about the possibility of antibody enhanced um, disease, but at least the best to I understand with SARS-CoV-2, nobody's been able to demonstrate that um, to be the case. But I think we have to keep an open mind, and as we do these studies, maybe we'll understand that a little bit better. Mm.
Okay, let's see. Does anybody else have any questions? Give it just a second. I don't see anything else popping up. So Dr. Nath, again, thank you for presenting for us today. Everybody is, I'm sure, really enjoyed it. And thank you everybody else for joining us today. Make sure you complete your evaluation form if you're interested in getting that CME or CE. And then if you're interested, our next session is on July 28th. And that day will actually be the second part of the two-part pediatric series that we had to reschedule from May. And it's recognizing and treating orthostatic intolerance and mast cell activation syndrome. So we hope to see you there, and everybody have a great rest of your day.
Well, thank you for having me. I enjoyed the discussion.